Next comes the professor, Dr.Channesh. He's a phenomenal, he's a very good clinician. The best part is he wanted to really do. He has used all his resources possible, including his. Naturally, the students don't have a choice. No, if sir has to say, they have to work. I don't know how many students he got hold of. So happy to have you, Channesh, here. So he has done like, especially the last 1 month was very hectic for you, correct? Because I was on his head. Okay, I was on his shoulder, I was everywhere on his body. Okay, to make him complete and stand here. I know this will be a proud moment. This day, all their pain will become a happy moment. Whoever has felt like, why did I join this fellow? Why is he? Even Vasanth sir is not asking anything. This fellow torture is not enough. Many people would have thought, sir. Okay, but one person has to be like that. The other person has to hold the responsibility, hold you accountable. Okay, thank you.
Very good morning, everyone. First of all, I want to express my acknowledgement to all our mentors, buddies, and my family members and my institution. So as everyone has their own stories of their journey, even I have, I want to keep it that story for the evening. So lot of there to tell. So just want to start with the case. This is the case. The lady came with the treatment plan and the sequence. So she has visited other dentist for the previous treatment, and she has some of the problems with her previous prosthesis, and she came with a complaint of fracture prosthesis and one ill-fitting prosthesis bridge. And she is concerned. First, she want to get it corrected with the ill-fitting prosthesis, then others which are having a PFM exposure, like metal exposure in a PFM crowns. So she was fixed with her treatment, like she want to start with this, then other side. So I told her, if I continue with the same line of a treatment, so my treatment will also not last for long. So I educated her. So I told about this protocol. I did with the muzzle examination. There was no symptoms. Then after TMJ, I could appreciate some clicking sound. Then because of all these examinations, what I am doing, she felt I am doing something different. So then she was convinced about the treatment line. So she was okay with my treatment line. So she thought, okay, she will proceed with the what treatment I am suggesting. This was the pre-op radiograph. This is the relevant pictures, like you can see the fractured PFM crowns, and this side there is a dislodging bridge. I think in this picture it is very clear in the left side. So bridge is getting dislodged when she bites. So she wanted to replace that first, then with the fractured PFM. The right functional, right non-functional, left functional, and left non-functional. So all are interferences. So steps followed. It modified FES impression was taken and cast was fabricated. Phase 4 record was done and COIS deprogram was fabricated, and CR bite recorded, and Dawson bimanual palpation showed a load test and negative. The first point contact recorded, and it was matching with that of the model also. So this is the picture of first point contact in the mouth. Then it was matching as same in the mouth in the model also. So the vertical at a first point contact was 0 plus, and vertical at MAP was -1. So after removing the posterior segment, so vertical was at the -1. The anterior coupling was seen 2-3 and 3-3 contacting, and 1-3 and 4-3, and it was a type 2 scenario. And with the 2-2, 4-2, 1-1, 4-1, and 2-1, 3-1, and 2-2, 3-2, there was a type 1 open bite. Okay, scenario 7, a open bite. Then on a mock-up model, teeth with existing crowns trimmed off. so it was noticed that intra-arch occlusion space was very less to fabricate the crowns. So it was not sufficient space. So I raised the vertical of from -1 just near to the 1. Then by raising that 1 mm vertical, I could get a sufficient space for making a posterior crowns. So hence my vertical treatment in anterior was fixed to 0, little more than a 0. So this is after removing the posterior segment. This was the anterior coupling. So this was the treatment. It is completely additive case. So posteriorly, wherever there was a previous crowns and bridges, it was planned to place the crown and bridges. Patient was not willing for any implant. Then anterior, from canine to canine, both in upper and lower, so it was decided to do a composite restoration. So my treatment line, like patient has refused for the implant. It was, as I said, it was a posteriors, it's a crown, and bridges wherever there was a bridges earlier. So and restoration in anterior, upper anterior, it was decided palato incisorly for uppers and labio incisorly for the lowers to get the proper guidance. So crown and bridges in the place of wherever they were there in previously, and post-operatively DASA was planned to give as a night guard. So this is the lab instruction given for the wax up. So this is the final wax up what I have received. So unfortunately, after this stage, patient couldn't report back because of her illness. She admitted to hospital. So I had a treatment plan, so that I will explain what I will be doing after this wax up. I want to remove the previous crown and bridges, but as she is having the crown and bridges in all the 4 quadrant, so to cut open all of them together was not possible in one day. So it was tedious process to cut open the bridges, previous bridges. I planned to fabricate the temporaries from our previous pre-op cast. So it is the replica of our existing crown and bridges. So one by one, I started removing the crown and bridges from the quadrant wise. Then immediately I used to replace that space with the temporaries what I have fabricated out of our existing crown and bridges. So after all quadrant preparation was done, so fresh temporaries are fabricated using the wax up what we received from the lab. Then patient was recalled, and deprogrammer will be under the deprogrammer. The temporaries are going to be replaced. Once we achieve the posterior this one, the anterior buildup will be done. So to achieve the proper guidance. So once with the composite, then the posterior quadrant wise we are going to replace with the permanent crowns. So just before coming here, patient has reported. So I could do only posterior temporaries, and there was a decent contact. What I should want to tell here is the patient who is comfortable with our previous existing ill-fitting prosthesis should make out with the temporaries only that I got a decent contact in everywhere. Only in premolar that intensity of contact was not that great. So she was pointing out. So I can I can bite properly in molars, but in this teeth that contact is not that great. So this is the change what she can appreciate. So unfortunately I could not finish. The temporaries I have placed and picture is not taken for her. Just before moving from my place to here, I just cemented and started my journey.
Everybody believes, right? Tell him you believe, yaar. Can't you understand his reaction? We believe, Channesh. Wonderful, wonderful.
Thank you, sir.
Thank you for this presentation. Okay, great. No exercise. Don't escape from the case. Okay. Wow. Next comes another first time presenter, Dr. Shweta. She is a very adamant woman. Do you know why I say that? She is very adamant that she has to finish. I'm just going to post the final list of people who are selected as graduates. Some people have not, some work is there. They have promised me that they'll submit the exercise. I have put it in the wait list. Okay, that is the final 2 o'clock or 2:05 I'm going to post. Just 2:06 a message comes to me personally saying exercise completed, jumping with all emojis, all those things, and completed, as if it was like as if like delivering a baby. That level of happiness. You understand the pain what I'm trying to say. She was so happy, so confident. I just stopped posting that. I have to edit, I have to add the list into the top list, then I have to post her. Okay, yes? Okay. So I'm going to call, she already entered, huh? Okay, thank you. Dr. Praveena. Um, Praveena's husband is my senior in college. And many people sitting here I would have called. If there is one mentee whom I have not called for this entire 1.5 years, she is the one. You understand, no, why I didn't call? Radhesham sir, you can make out. I never called. I don't think, I don't even remember talking to her over a phone, or maybe very vital. But the way she submits the exercises, the way she does the job is ultimate, and it's phenomenal. So, welcome.
Thank you, sir. Thank you for your nice words. But I'm a slow learner only. But the way they have done their exercise and all made me do everything. And I'm here now. And as they will start, accountability is the glue that bonds the commitment to results. So I realize the value of these lines in my ODD journey. And I would like to thank Vasanth sir, Ramesh sir, for including such valuable moral values, and in addition to the occlusion details. So I am Dr. Praveena, having my orthodontic practice in Mylapore. So I am going to present a case on full mouth rehabilitation. Here is a patient with a chief complaint of difficulty in chewing food and wants to replace a missing teeth. So on detailed examination, on extraorally, there were no signs and symptoms of TMJ or muscle, and intraorally we can find out the signs like incisal tooth loss in the lower anteriors and enamel loss in the upper anteriors with dentin exposure in the premolars and molars. So these are the intraoral findings, and her dynamic contacts were checked. With protrusive there is interference, and in right latrusive and left latrusive there are interferences. So ODBA test has been carried out. This is her OPG, and Facebook CR record has been taken. The model has been mounted, and the first contact has been matched with clinically and in the model, and cast analysis has been carried out with the posterior segments and without the posterior segments. And here there is interference we can see, and this is this is the MIP occlusion and the CR occlusion. So we can find out the scenario is 7 here. So we did the equilibration and concluded that it's not able to achieve anterior contacts, so it has to go for additive. So the treatment options will be the first option as usual. So it's ortho combined with equilibration and addition, and the second option is without ortho, that is equilibration and additive. As the patient was to travel, so she opted for the second one, and the plan is planned crowns in the upper and the lower anteriors and bonded restorations in the premolars, upper as well as the lower, and she had implants in the 1/6, 2/6 and 4/7. So that has to be replaced with the crowns. This is the treatment plan. So the instructions has been sent to lab for wax up. So wax up received, and static and the dynamic contacts has been checked. So in the cast analysis, it's been inferred that 1/7 and 4/6, 2/5 and 3/6 will require equilibration during dynamics. So the treatment has been started. So did the test drive with the ProTemp, but then I was not aware that the test drive has to be removed on the same day, but later only I came to learn that. So I left it like that for 3 to 4 days. In the upper anteriors and premolars, it got chipped. So I maintained the contacts by adding composites in that region, and then I did the process. So this is a test drive, and the anteriors were prepared in the upper and the lower, so for the crowns, for full crowns, and the temporary crowns were delivered. Equilibration has been done, contacts has been checked, and in the next step, premolars were prepared for the bonded restorations. So bonded restorations has been delivered, and a temporary crown has been given in 1/6, 2/6 and 4/7. So in the meantime, equilibration has been checked. So for final restorations, zirconia crowns has been delivered in the upper and the lower anteriors, and the contacts were checked. This is before and after. Front view, right view and the left view with the protrusion. So no interference. So canine guided, sorry, incisor guided, and in left lateral there is canine guided occlusion. There is interference earlier, and now it's been corrected. So right lateral view and occlusal view. So I have got decent contacts, but yet some more corrections needed. So the procedures yet to be done will be, I need to do bonded restoration in 3/6 and 3/7, and to provide DASA as nighttime wear. So the crowns given on implants are temporary, so that has to be replaced after a year. So we have to check for the bone remodeling, and then only we have to give the permanent crown in permanent implant crowns. So recall will be like, in the first year we have to call once in 4 months, in the second year once in 6 months, and every 4 years we need to take the records and check for the contacts. So thank you. I would like to thank Vasanth sir, Vijaya ma'am, Malar ma'am, Ramesh sir for making my ODD journey very interesting and more effective. I would like to thank my family, my clinic staff, my team, and I would also like to thank Anand, Dr. Anand for doing the process work for me. So thank you. Thank you for this opportunity. Thank you so much.
Thank you. Wonderful. So happy. Anand sir will be very happy, right? He did our 3-day format, sir. 3-day format course he finished, and intelligently he has put his wife for the bigger one. Sir, he realized what is needed. 2016. Anyway, I was there in all the retake, no, so I know all the batches. Periodontist. And he decided what it demands. So he sat in the practice, he made the right choice. He made Praveena to be here, and the combination is very well, no? She knows the subject, he knows the subject, he is going to talk with the patients are ready, and she is going to execute everything. And all the prosthetic work, sir will take care. That's amazing. Next I'm going to call, thank you Dr.Meenakshi for coming. They didn't have a plan. Frankly speaking, they didn't have a plan to come. Because then I said, like, you have done cases, you are doing cases, and the one thing I love about ma'am is she practices a multidisciplinary, in the sense the biggest compliment what I can have is an OFP person coming and learning ODD is not easy. She can relate what I'm trying to say, okay, right from day first lecture I'm trying to say. So what I'm trying to say here is, she has completely, this is a success. Because I have done my fellowship in orofacial pain, and she has done her fellowship. She is actively practicing that also with trigger point injections, everything. A person like her coming and practicing this and believing in this, and she has to say what, maybe evening she may talk about it. So what is the difference? The best part is she incorporates all the concepts and applies it to the right patient. That is very, that needs a lot of thing. Only thing is, I would strong suggestion is she has to do documentation on everything. She doesn't have time. That's a problem. Anyway, ready, Abba? Okay, please come. All these are last minute done. She wanted to come only by, they came around 11 or 12, 11 o'clock, 10:30, 11 only they landed. And they are straight here. So she is presenting here. Yes, ma'am.
Hi, everyone. So this is my case of minimally invasive FMR. But I just want to share few things before we start. Earlier, I was doing few cases of FMR, but it was all 32, 28 crowns. And at that time also, there is one mentor I had, and that is Dr. Jyoti. She helped me a lot. I have never met her in person, but see, first gratitude goes to the first mentor. And then ODD comes into my life and everything changed. Dr. Ramesh sir, Dr. Vasanth sir, ma'am, everyone is so dedicated. I have not seen mentors like you. Thank you so much. Like sir said, I have done OFP fellowship also, and he's absolutely right. Every time there they said occlusion doesn't play a role at all. But somewhere in my mind, I was sure that it has a role to play. So that's when then what you say, na, ki when you think about something, universe takes you to that path. So I think that is the path which is ODD, and I'm really thankful I joined this course. So minimally invasive FMR is something which is new to me. That's why I chosen this case. So the patient only comes for the change of this crown, front tooth crown, but I saw there are multiple signs of occlusal disease were present: gingival recession, multiple class 5 lesions, broken incisal edges, crack lines visible. Bone loss was there, though the hygiene was good. So patient was made aware of these issues and patient get ready to take the ODBA test. Pre-records taken, photos, impressions, radiographs, OPG. Then muscles were palpated to rule out any joint or muscular issues. The CR bite is taken and is verified by taking the first point of contact. Treatment planning executed on articulator, records and photos taken to check guidances. So as you can see, the occlusally the enamel is very good. It's only at few places you can see the migration and incisal wear. This was the bite, and these are few lateral guidances and protrusive guidance pics. So planning was done on the equilibration sheet. As the enamel was good occlusally, so we decided to go for ortho and equilibration or only equilibration with the guidance build-ups. Patient given both the options, but she chose equilibration and guidance with composite and just the change of the crown. So equilibration was done on patient's mouth, and after equilibration I get the decent contacts, and the crown was changed and the guidances were given with the composite only. So, and the protection of the stomatognathic system by giving the splint. So mine was a very small case, but I thought that this is something very new to me, that the patient just came for a crown change, and I'm able to convince the patient to take the ODBA test and done the FMR for the girl. Thank you so much, everyone. Thank you, sir.
Thank you, ma'am. Doing 28 crowns, tabletops, that was a dentistry before. That is a huge change in the thought process, and doing it everything in a minimally invasive. Hats off. Thank you for presenting this. Next, I'm going to call Dr. Saily here. We have a very good bond of friendship. We have studied together with one of our greatest mentor, Dr. Stuart Orton Jones. We have been there together learning from him, and she has a huge respect for Stuart sir, like what I have, and she has a special bond, almost like a daughter. So she couldn't hold her tears when we lost him. Okay, so she's a very composed but very determined woman I have seen in my life, and she should be very happy. She was very cloudy. Okay, she knows the subject, she understands, she applies the knowledge, everything I know, but end of the day, a cloudy feeling will be there, no? That clarity has to come, no? Is it correct? Can I do this? Huh? I think nobody is cloudy now, right? Okay. Yeah, start.
So hi, I am Dr. Saily Joshi. I'm from Pune, and I'm sure each one of you must have had at least one favorite patient in your practice who left a mark on your heart. isn't it? So this is a story of one such patient, a story that led me on to the occlusion-driven dentistry. So it wasn't just the patient herself, but her son's unwavering faith and determination that his mother receives the best treatment possible. So 60-year-old female presented to ORIs with a chief complaint of missing 3/6 and a failed bridge in that quadrant. But what caught my eye, being Stewart's student, was the palatally placed upper right canine. And that's why I asked her, were you able to chew well when the bridge was intact? And that one question led the door open to many stories, saying that for years together, the patient had been to several dentists wanting to get some solace with the banging of the bite that she had, and that she wasn't able to bite comfortably in spite of any treatment. So this was in 2019, before COVID had struck. And at that point, we discussed implants and the need for correcting the bite and pros and cons of a bridge. But they decided to not proceed with the treatment for financial constraints. I lost track of the patient. In 2022, I got a call from them. This time, they were determined to restart by correcting the bite, choosing implants, and doing things the right way. So I mounted the casts in Centric. I did not get any photos or any documentations of the first point contact. No TMJ symptoms were recorded at that point. I consulted the orthodontist, showed her the casts, the mounted casts, and I thought she had a magic wand and everything's going to be straight. There was no communication from my end as to what I am expecting from the treatment. So this was, luckily, I clicked a few pictures. This was the scenario intraorally on the right and left. So ortho treatment went on, and after the debonding, I mounted the casts again, and to my horror, the curve of P and occlusion had a mind of their own. So I communicated the findings again to the orthodontist. We started treatment again. Patient was always cooperative, and some lessons take a long time to sink in. I have still not maintained any records of the mounted casts. By this time, I was getting nervous. The patient was creeping into my dreams. And the worst part is the son and the family, they believed in me 100%. They used to always say, you will give the best. So with this background, I enrolled for ODD. Just imagine, starting with documentation, 2 sets of models before treatment planning in advance, orthodontic work with a clear road map. All this was like a jackpot. I only wished I knew this earlier. So meanwhile, the orthodontist was getting married. Patient had moved to another city. Everybody seemed to move but me. I was just not having any progress. So in finally December 2024, after both the hands-on, I felt ready. I was determined than ever to finish what I started. So this was the second time debonding. I was sure no more ortho work. I have to do this restoratively. Post-orthodontic treatment, the scenario was like this in MIP. We recorded the centric bite records. First point contacts were matching. I was following exactly what the mentors had taught, each and every step. I just love how Vasanth sir makes it simple for us. Simple 5 pointers. What's the chief complaint? Does posterior adhesion need coverage? Same with the anteriors. What's the CR to MIP slide? And is orthodontics an option? So the detailed equilibration chart sheet, there was a variable overjet in MIP, and there was a midline shift. This is how I decided at treatment vertical the scenario looks like. Mind mapping made it very clear. A detailed wax up, I never ever imagined the wax up could be so detailed. I had written down exactly what is to be done for every tooth. This was the additive wax up. Some teeth are marked which the lab is not supposed to touch. Maintaining all the steps, maintaining the records. Composite build-ups for the anteriors were done. And this is the transition at the end of the treatment. So these are the pictures in all the guidances. This is the variable overjet. These are the changes in the photos extraorally. Whenever I used to see sir's pictures on the platform, I used to wonder if I will have such cases. I'm so happy, sir. You helped me achieve this. Like I said, I follow everything what the mentors teach us. No case is complete without a celebration and a review. The review is in Marathi, so you would not be able to appreciate, but they've been very happy that they made this choice. So I'm not very particularly happy about this case in terms of perfection that I have achieved, but it really gives me sound sleep at night, and that's priceless. I chose to present this case because I deeply value what our mentors have taught us. And every step that there is for a reason, built over years of hard work and wisdom. I immensely value that. A heartfelt thank you to Vasanth sir, ma'am, sir. My co-participants have learned something from each one of you. And this case may not have made me richer, but it definitely made me wiser. So I end it just in time. One case, many lessons, and a heart full of gratitude. Thank you so much.
Wonderful, wonderful. The same cloudy face turning into a more confident face. Thank you for this wonderful presentation. So get ready. You all know who has not presented yet, right? So there is a dynamic couple who are going to present. Together you're going to do it or one by one? One after another? Together, with two mics. Oh. Providing 20 minutes or 10 minutes? Huh? Naturally, two participants here, we have to give 10, 20 minutes, we have to give, no. So that is there. So we have some more great presentations are there. Okay, so anyway, it's on time. I don't know how it is going on time. Because we calculated the time. You started. Radhesham sir is the reason he started. How come you finished 2.5 minutes one FMR? Only God. To talk about the protocol what we taught you, it takes at least 5 minutes. The best part is 2.5 minutes. He decided, I have done so many. One boxes you put now, finished. Hey, don't ask me any question. I have 10 cases already there. So who is ready? We'll start, Ronak. No problem. 2 minutes. Again 2. I can imagine her tension, no? Oh my God, these people are playing with us. Great. Are you enjoying the symposium? Okay, we want this number to become a minimum of 1,000 members gathering, where a big event has to be conducted, where you all people having a symposium of 2 to 3 days, staying together, sharing your journey, bringing the best of more mentors. No, our mentors are there, wherever I have learned. Maybe if they agree. Maybe it's very small now, they may not agree now. One point of time, this will go to their ears, right? Somebody somewhere, something, our intentions are there. I always say. So this is like a dream come true for my guru and mentor Vasanth sir. I know how happy he'll feel. More than anything, if you buy him 50 sovereigns of gold, you won't do, but if at all you do also, that is not going to make him happy. If you present just 5 cases, that is the real, because in this entire journey of me traveling with him, this is what I wish to. This is the respect, this is the credit he should have got from all the mentees. These mentees are there, no, they'll go, they'll learn, they'll practice, they won't even come back and say, there are really grateful people. It's not that they don't want to say, there is no platform to come and say that we are doing. So that is the idea behind this symposium. Thanks. So you can start.
Yeah, good afternoon, respected mentors and all my dear friends. And what a proud day it is today. I never thought that I will reach this point. Though I had done some 2, 3 courses of so-called FMR, still I didn't know anything, no ABC also. And in one of the courses, I met our dear mentor, Dr. Ramesh. I told I didn't learn any FMR, but I learned you. I found you. And and I no
Yes,
Mala.
sir.
So Dr. Ronak only told me blindly follow him. You will come to know what is occlusion, and I did that, and I joined this course. I am really thankful to God that this happened. So I tried my level best, and being a first case, I am sure there are many things which I have to work on. So to get a smile on anybody's face is what a dentist is for. So this patient came with a chief complaint that she was unable to chew and she wanted to replace her missing teeth. And in medical history, there was nothing significant. Dental history, I found few missing teeth and few root stumps, and occlusion eyes were open, so I was able to see atresia in lower anteriors, and she had a poor oral hygiene. So all the extraoral pics were taken. These are the intraoral pics. Then occlusal view. I extracted the root stumps and waited for the healing to happen. Then after the healing was complete, the impressions, and these are the master cast, the pin cast. ODBA test was done. Right masseter was a bit tender, but there was no TMJ symptoms, so no OPG or any MRI was required. Deprogrammer was given to the patient. Facebook records were taken. Upper cast was mounted. Then with Lucia jig deprogrammer, the CR record was taken. Load test was negative. And then CR mounting was done with the help of measurements and the differences. And the mounting was done. The first point contacts were matched. And in upper cast also, the first points matched. So similarly, it matched in the pinned cast also. Then the initial planning. So the initial planning was done. So only there were upper 8s which needed equilibration, and 2 bridges were decided, and composite filling for the lower teeth. Patient didn't wanted to go for extraction of third molars, and when it was mounted, the master cast at CR the reading was noted, it was plus 3.5. At MIP, it was minus 3.5. And the hit and slide was 7. And I was scared after seeing this. And same readings were there with the paint cast also. And when I removed the posterior, the reading was minus 6. So scenario 2 was noted in the anteriors when the posterior component was removed and the lower atresion was there, and the contact was only on 1-3 and 2-3. So when the posteriors were placed, I was able to see the third molars almost touching the gums and the third molar hitting the second molar. And then the equilibration was done, everything was planned. And on the model, how I equilibrated, I noted that. Wax up instructions were given. So this I received the wax up from the lab. So then equilibration started in the mouth, and I was able to get the dots. So then the index was prepared in the lab putty. And temporization, this is no prep temp. And I was not able to equilibrate because it was not sitting properly in the mouth. So I had to think that because the lowers, the temps broke again and again. So when it was not stable, I was not able to equilibrate. So I did the crown reduction for lower, I made the provisionals, and then I did the equilibration with the equilibration jig. And static centric contacts were done. So then anteriors, after I sent it for the BISC trial, the posterior ones, I came to anteriors for a composite build-up. So the putty index was prepared. Yeah, so the putty index was prepared, and it was rubber damped, and the putty index was set. Then it was one by one, each and every tooth was given that height. So patient was happy. So I received the BIS trial, but there were no contacts. So I added pink composite on it to show the lab person that these crowns are way down. I was able to get all my static contacts. So this BISC again went for another BISC trial. So this was the final BISC which I had got. Then I did the upper crown reduction, and the bridge was, and the provisionals were done, though I am not very happy with the provisionals the lab had done this time. So still the BISC is awaited, and I have reached till here. And these are the before and after. And thank you.
Great, Shweta ji, for the first presentation. And every time, are you tense? Why should I be tensed? I'm always relaxed. Okay, that is the reaction she'll give. Okay, so we'll start with the Mansi. Everybody knows, right? I call her a real action queen. If you give something, exercise is next. She doesn't care much about exercises, but she'll put it into action in the patient mouth. Whatever you teach, no exercise, nothing. Direct action into the patient mouth, and she tries everything, and everything on earth below ODD, she has done everything in the patient mouth. That I know 100%. Highly active, very, active ODD mentee who clinically applies all the knowledge what you have sent into the patient. That's very tough. Till articulator you can play. When you want to put something in more than articulator, she loves to play inside the patient mouth. Well, let's see what she has played here, right? Okay, we can start.
So good morning everyone, and it's an absolute honor to be presenting here after 15 years of my general practice that I did after my PG in prosthodontics. And many stories are similar with so many people here. Some I relate to Dr. Vasanth as well. So when I came out of college, I also felt like he felt totally ready and armored to conquer the world. But dentistry in India is way different from what we believe. And here I started my journey in 2010 as a general dentist and not a prosthodontist. So after years of struggle and the quest to find out what I actually wanted to do in my life, I landed up here in ODD. And as I resonate with Dr. Shweta, I was not at all convinced with 28 crown concept, and because of which I couldn't do many FMR cases in my practice. And the struggle kept on going. Today I'm happy to present a case which is very close to my heart, and I cannot thank my mentors enough to help me discover my Ikigai. So today I present before you a prosthodontist converted to an ODD stomatognathic specialist, as Ramesh sir rightly says. And this is my conversions. I would like to tell each one of you that if I couldn't do in my 15 years of practice, and I could do in 1 year of practice, every one of you can. This is like more to be added. Yeah. So this is my first case presentation here. This patient, 55-year-old anesthetist who lives in Canada and whose wife happens to be a dentist as well, reported to me in 2023. His only complaint was that I have a few missing teeth which I want to replace. That's all. This is his photo from 2023, and all I could see was that I need to do some dental work as a general dentist that I was back then. And these are his pre-treatment records. I could notice that there is a severe jaw deviation, clicking, hypermobile joints and failing dentition along with crossbite. But at that point of time, these were not of concern to me. As how we say that your eyes see what your mind knows. So this is the treatment that I have done that time. And it was time for him to move back to Canada as he used to come in intervals. Temporaries were delivered, few implants were done, prophylactic work was done. So in May 2024, the patient was back, and by now I had found my new occlusion eyes. So when I saw this, we had just done a few online lectures with our mentors, and I was absolutely terrified that what am I going to do. I sent this video to Vasant sir, and he told me, "You're not ready right now for this." And I was like, "Sir, I can't help it. He's here for a month, and I know I cannot go back to my previous dentistry here." So, like a lens refocused, everything snapped into place. When the student is ready, the teacher will appear. And here was Dr. Vasant for me, for my rescue. And I cannot thank enough for every moment that he has spent with me, morning to night. He has helped me with this case. So the first challenge, since I was a naive to all this at that time, and I had no absolute idea what I'm going to do, the first challenge that I faced at that time was, how will I deprogram? I'm sure all of you know by now, and it's not a challenge anymore now, but it was back then. So, and I would like to show this video. At that time, we were not taught about this deprogrammer, like before the first module as well. So I fabricated a different kind of DASA, and look at how his joint is moving. His jaw was dancing, and so my head was spinning. So So Vasant sir told two things to me. I'm sharing this case only because I think all of us have a lot to learn from this case. He told me two things in this. Ask the patient not to open too wide. There should be no translation, only mild rotation. So little open, close, tap, 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 and ask him to move front, back, tap, tap, tap. And it genuinely helped. So this is from my confusion to clarity. If you can see in the first image, how the centric he was giving me, and to a proper single point centric he started giving me. Now came another challenge. He had no posterior teeth on right and no posterior teeth on left. That time I didn't know how to record the bite for this particular patient. So Vasant sir, I called Vasant sir, he was traveling to somewhere East India. He would be in the bus for 7 hours, and then he would take a halt and call me back, and then he would say, "Okay, do this now, okay, do this now." So I gave these resin stops here for the bite to be recorded, and one particular point of time I couldn't reach him, and I couldn't hold his jaw in centric. That time we didn't know about the composite indexing thing. So I remembered one thing from the last man lecture, the last man technique. So I made that hole, and with the help of composite button, I recorded the centric at that point. This took me 5 attempts to take this bite because I was not aware about the wax wafers. So I was taking the bite with putty index. And every time I would come to mount the bite, because of the elasticity of the material, it would not hold. We had no clue something about lab putty exists. So I took the bite with aloo wax. That also, sir suggested me, you take with whatever material you have, but don't use an elastomeric material. So challenge number 4. On India trips, these NRIs have a very high time constraint. And I lost 3 valuable weeks in getting the centric record right, and I now had only 1 more week left for the final treatment. So the prostodontist in me came alive, and I did the wax-ups for the anterior. Time for some action, and I converted through ProTemp to check my bite. The front wheel of auto was set by now using composites. Now the time for passengers to enter. And these are the temporaries that I gave him. And after giving the temporaries, I was checking the guidance. On the left side, I was able to manage with canine guidance. Now came another challenge. What to do about the cross-bite side? Again calling up, sir, what has to be done? Actually, I was on the stage of crying that time. So sir guided me. It's a very important learning. Please imbibe this and click a photo if you want. So sir told me to give guidance with palatal incline of upper and lingual incline of lower lingual cusp. So I was able to manage this at my temporary stage. Protrusive definitely needed improvement, but I had no time and I sent the patient. And another thing, the patient told me that he had a flight a day later. I was planning for an overlay lower deprogrammer, but suddenly he calls me in the morning, I'm flying tonight. So I made this lower deprogrammer, and the patient was not very comfortable wearing this. Maybe the incline wasn't correct. I had very less time. So sir asked me to buy asked him to buy an aqualizer in Canada. He was wearing this and he was very comfortable. What this did was that the patient was so comfortable, he didn't want to come back for final treatment. And thanks to the dentist in Canada, one of the bridge came off and he fixed it so awkwardly that this time the patient had to come back. So he came back in December 2024 after our second module had happened. And this time, we begin with the final work. And this time, I was armored with knowledge, equipped with precision, and ready like never before. So, as sir says, every case is different, and you have to use your mind through our exercises, what to do. This time, I was doing the jig trial for my implants, and I fabricated the resin buttons on the jig trial only, and took the bite. So, it reduced 1 appointment. Then, detailed lab instructions, as we all have been doing by now in the final crowns. So I fixed the final work. Because of short time, there was no time for checking the glaze thing for me. And this is the bite. Protrusive needed improvement, so I added composite on 1-1 to gain the correct protrusive guidance. These are the centric stops. Canine guidance I could get on the left side. And now, to my horror, because I couldn't check the glazing, the premolar guidance that I had created on the crossbite side was gone in the final. I called up sir and I was almost crying, and he was saying, why didn't you do the glaze trial? And I said, you know my problem. So what to do? Then I checked my guidance was on 1-1 that I had built up for the protrusive guidance. Sir told me it's not the most ideal way to create lateral guidance, but since it is the farthest from the TMJ, just keep your fingers crossed that nothing should go wrong. And this is my bite guard to secure that. This is the finally transformed bite. I would just say, progress, just make progress. It's okay to have setbacks and the need to do do-overs. It's okay to draw a line in the sand and start over again and again. Just make sure you're moving the line forward. Move forward, take baby steps. Then change will come and it will be for good. Thank you, one and all.
Wonderful, wonderful, Dr. Mansi. The best part is that final slide, she said, no, we talk about digital smiles, digital smile designing. She used a word, a functional smile. It doesn't look, it's not about the looks. End of the day, you can live a happy life with a proper function. So that is the crux here. For beauty, don't destroy function. Always remember this. You can never give what has been created by God. For me, for sir, it's different. Okay. So, okay. So now I am going to call. Ready? Yeah? No? As if a guru is blessing. Wait, man. Why are you coming here?
How polite? How should I mean?
That is northeast. He said, no, wait.
No, see, I'm feeling tensed up for the patient, right?
Me and the patient, I was sitting on the chair, patient was lying down on the chair and we were waiting for Vasant sir's call. Evening 7 o'clock, 8 o'clock, he will call. I'm telling he will call. He's like, okay, no problem. And he's so cool. I know you can do. I'm asking him, your wife is a dentist, how you have landed up like this?
He'll send a PowerPoint. It can never be downloaded. That's the speciality of Dharmendra. The resolution will be too high. The images are really very, very high. And we have been sitting with Lemon Tree's Wi-Fi for 1 hour, 1.5 hours. We tried all the modes. Nothing is downloading. Let's see what he has done.
Good afternoon, Vasant sir. Good afternoon, Ramesh sir. Good afternoon, Malar ma'am and our guest. Good afternoon, a very good afternoon to all my colleagues, seniors and buddies here. Myself, Dr.Dharmendra Sindha. I am practicing in Bharuch. I am a prosthodontist. So this is how I landed up here. This is my rebirth into equilibration. We have been doing equilibration in our prosthodontist tenure in college only in one type of cases, that is when the patient is having edge-to-edge bite and the patient is interested in doing a smile makeover. Because we don't have any space there, so there is no other way but to equilibrate your posteriors. That is the only scenario in which I have learned to do equilibration. So this is my second rebirth. First was in 2015 when I joined MDS. That was when I started learning equilibration. And again in 2024 when I joined the VASANTH Dental Academy for this course. Okay. So as you can see the patient name, it is my very own surname, Dr. Shreya Shinda. So as ma'am has already established that wife is always right and she should be listened very nicely. So she has some pretty teeth, you can see, and her only complaint was my canines are getting flat, I am having some headaches, and she is the one who basically pushed me for this course, because whenever I used to talk with my friends or with my wife about something about occlusion, I used to just answer in one sentence that it is very complicated, I won't be able to explain. And what I learnt with 2 days of lecture from Dr. Ramesh sir is that his words were very simple. And the very next day I was able to discuss with Dr. Nihar and everybody else. So my wife pushed me that join this course, it would be easier for you to communicate as well as you can treat me. So the first picture is when her canines were flat. This was taken after the canine rise exercise was done in her. So in the first picture you can see the flattened canine. Her second complaint was frequent headaches and burning sensation in buccal mucosa and vestibule because she has oral lichen planus, mostly stress induced. These are some of the pictures, upper aesthetic view, lower aesthetic view. Most of her teeth are very good. Some very good anatomy. Okay. Now when I check the occlusion in lectrusion, so slowly and slowly, because 2 years back this was not there, she was developing a pathologic group function on both sides. And this year, I just treated her like 15-20 days back, very frankly. I had completed that equilibration on model 6 months back. I brought that models and showed it to Ramesh sir and Vasanth sir. So in protrusion also, now her 6 were, distal part of 6 were touching. So on examination, on palpation, the TMJ was absolutely normal. On muscles, right side masseter was tender, and there was one trigger point. There was signs of occlusal disease. Wear facets were seen in posteriors, incisal edge wear is seen, and worn out canine tips. Okay. So I started with all the records 6 months to 8 months back. I took the impressions. I took her Facebook record. I mounted her upper cast with the Facebook records. I prepared one coils type anterior deprogrammer, and then we freeze the bite and recorded her mandible position in CR. I added the bite for the articulation, and lower model was articulated on her now. I am using a different articulator. Okay, and the first point contact matched nicely. Then I started my treatment plan as per ODD protocol. I removed the posterior segment, and I very nicely did the equilibration of lower anteriors. It was so nice, I will show you the picture. And then when I added the posterior segment, I realized that I am trimming so much in her mouth. And I was afraid to do it in her mouth basically. Okay, so one more point, on models it is easy, on ceramic it is mandatory. In your wife it is challenging, and when your wife is a dentist. So I did 2 treatment plan. One was pre-build-up, so I started with equilibrating all the teeth, and one was post-build-up, when I thought let me build up the equilibrated anteriors so that I don't have to trim the posteriors much. So this is the first change in my treatment plan which came. This is the anterior contacts which I got after equilibration. Everything was perfect. Now when I added posteriors, you can see the lingual view. All the anteriors are touching nicely. When I added the posteriors and few taps, I got some good contacts and I stopped there. But my anteriors were not touching palatally. So I decided to change the plan, and I added some composite, and once again got the good anterior coupling. Her canine guidance was achieved. Start of guidance, end of guidance, start of guidance, and end of guidance on both left and right. Then since I had to submit a properly documented exercise, I wooed her for this thing, and she was ready. I narrowed the anterior my AD deprogrammer for making an equilibration jig. I started with equilibration. In few taps, the posteriors were already good. You can see the jig in place. Slowly and slowly. Blue sometimes leaves so much marks, so I was always using red in between. After few taps, I realized that my marks were getting shallower, not that much dark. Then I realized that I was not trimming my equilibration jig at the same rate in which I was doing the equilibration. So once again I did decent enough marks achieved with the blue 40 micron paper. Then I did the composite, anterior composite build up, and these are the marks I did achieve. overlap with the red paper. So this is the anterior composite buildup which I did. Okay, when you are treating specifically your wife, there is one more factor that comes in treatment planning, that is comfort. After everything, she was saying that this midline portion is tight, tight, tight. And there was one extra contact there, which I repeat. All the lines in the back and dots everywhere and lines in the front achieved. You can see on both sides canine guidance. This is the comparison of pre-op lower aesthetic view and post-op lower aesthetic view after the composite buildup. Her overjet and overbite. I came to know one more function of that curve in the mirror. You can take one image like this. It's a good view. Front closed mouth, anterior guidance, no protrusive interferences. Anterior guidance left and right side. Functional side canine guidance right and left side. And thank you. I don't have a long-term follow-up right now, but few days back there was Guru Purnima. So thank you, sir. Thank you, sir. So this is my Guru Purnima gift to all of you. Thank you, sir.
Thank you. Thank you. Very impressive. That too, doing it on your wife is very, very impressive. It's not an easy task here. Great.
Like living with patient 24/7. The bravery ever goes to Dr. Sindhu.
You need documentation. Now you understood, no, why it is always rotating, loading. You see the quality of photographs. No, please start documenting. Okay? Right. Next I'm going to I'll call her my kid, Dr. Rupa here. Let's see what she is going to present. I have not seen her presentation also. Yeah, ready, Ronak? Yeah, come. Dr. Rupa. I am worried about the number of slides. I told her this is a time. Born and brought up by Dr. Ramesh, no, naturally it's imbibed in our blood, 400, 500 photographs. So, next slide, previous slide, video. Yeah, all the best, Rupa.
Thank you, sir. Hello, everyone. Good afternoon. And this is Dr. Roopavathy Ganesh from ODD Batch 1. And many of you as know, I'm from Sir's Clinic. So today I would like to present a case, which is not a very complicated case as many of them showed. It's a very simple case which involved equilibration and restoration as the major tools. So here the patient came with a complaint of pain in her upper left back tooth region, the 2-7. The pain was due to DC with pulp exposure. So when I examined, there was no symptoms of symptoms of muscles and TMJ, but there were signs. So these are all her tooth clinical examinations. She had multiple caries and the lower anterior wear was seen. So I started with preoperative records. The impressions were taken and Facebook record, and the CR bite was taken using the palatal type deprogrammer coils. So the first point was recorded, and these are the preoperative records. So the preoperative record shows the pathologic interferences in all the functional and non-functional and protrusive. So the equilibration starts here, the planning, treatment planning. So mind mapping was done, and this is her equilibration chart sheet. So here starts the sequence. So these are the models with bite and without bite, and the first point vertical HCR, and the first point contact here it was 2-6 and 2-7, and it matched with the mouth. So I started the sequence, and this line was drawn to show the difference between that hit and slide, that CR to MAP slide, and this is also the CR to MAP slide. And the anterior contact, the contact was seen on 1-3 and 4-3. So I have decided to retain that contact, but it was in case scenario 2. So decided to build the linguoincisal on all the other anteriors to change it into case scenario 3. So this is my equilibration sequence. So I have achieved all the contacts at back. And now comes the intraclinical pictures, that is the restorations and lower anterior buildups. So she had 3 crowns in the upper. So this is the equilibration with the cutting. And the wax up. The wax up was done by me with the blue wax on the posteriors and the composites on the anteriors. So the temporary was fabricated using the lap putty and the cold cure material. So before placing the temporaries intraorally, I have done the adjustments on the articulator itself. So this is how it looked initially, and after few adjustments, I got some contacts, and this is the final adjustments. So the pin reading matched with my treatment pin reading, like my treatment vertical, after the final adjustments in the model. So these are the permanent zirconia crowns, and the equilibration in the mouth has been done. So the dots everywhere and the lines in the front was seen. So this is a close-up view. And after building the composite, the case scenario changed into 3 from 2. So, but in the protrusive, we saw that the only single tooth is guiding. So protrusive adjustments were done to share the load to both central incisors. So these are the post-operative records. Now you can see there is no interferences in the dynamics. So post-operative articulation has been done and post-operative overlay has been fabricated and delivered. Yeah, that's it. Thank you. Thank you, sir. The intraoral credits goes to Ramesh sir. And firstly, I would like to thank my husband because he only introduced me, like suggested me of Sir's clinic. So then I approached them and they took me in and they showed me a new world of dentistry. Me being the newbie in this profession, I know many of you here are well practiced dentists, maybe not the occlusion, but you are all practiced general dentistry for so long years, but I was not like that. I am just a fresher. So sir and ma'am, they took me into this fascinating world of occlusion-driven dentistry, and everything I learned in college is all about the FMR, is the crowns everywhere, and I just read only one line, that is the Facebook and CR. One of my mentors showed me how Facebook looks, but the real Facebook and articulator I have seen after entering into his clinic, and the work he does was very different from the work what I have seen everywhere in my other practices or in my college. So, and when this academy evaluated, he asked me to join in this course to grow for my growth in the ODD. So I have zero regrets in joining this course, because if I can do like with a zero knowledge on this, and I don't know the word of equilibration itself before entering into his clinic. I don't know how Facebook is, how it's recorded, what is a CR bite, how it's recorded. I don't even know that what semi-adjustable articulator is. All I know is a 3-point articulator which we used in the clinic hospitals back in our colleges. So I'm very thankful to Ramesh sir and ma'am, and sir introduced me to Vasant sir, and I'm very thankful to Vasant sir and Vijaya ma'am also. They are very cooperative, and the one thing that I admire from Vasant sir is he is very calm and composed. He is very humble person, very down to earth. He is always there to reach for everyone. We all can reach him at any time without any hesitations, and even now I'm like, what to say, it's like whenever I discuss my colleagues or my friends from UG, they share a case with me, I'll be like, no, you're doing it in a wrong way. And I'm like, I'm not in a position to explain you. Even if I explain, you won't even know, because this is a very vast subject. And now I have been entered into it, and I have suggested some of them to enter into this because we all need this. I think I am being the youngest of all you, is the right choice to enter into this course, because practice makes man perfect. Once we start practicing this at the earlier stage of our dentistry, we will lead this into a successful journey. So I'm very grateful and thankful to Ramesh sir and Malar ma'am, Vasanth sir, Vijay ma'am, and to all my colleagues here. Thank you.
Thank you, Rupa. I'm very proud of her. Entire journey, she does everything. She does everything except some few intraoral, all ODBA test, everything she does phenomenally well. It's not very easy to work in my practice, frankly speaking. It's very difficult to work under me. It's very, very difficult. The way we think, way we work, no, it's totally, you understood, right? I know you will say that. Soujanya is here. Final.
That's why she told about Vasanth is calm.
I understood. Staying, because I know one day she'll be out of this practice, she'll go somewhere, she'll know the standards of the education and the practice values what she has learned. Okay, now she has taken a short break, and I would love her to be my consultant for life in ODD. That's my aim, and I wanted to be wanted her to be in this mentoring journey also. I have said to her also, because we have given her a short break for her life to get settled. That's all. I have never left her. Anytime our door is open, she can enter anytime, and we are ready to take you inside. Where's your husband? He's here, right? So she's a very special, like Jeevan and Satyan. She's like my one of the finest product what I have created to feel proud about. Okay, thank you, Rupa. Thank you for that. Yeah. Wildcard entry. It's okay. You ready? Become a norm for her. It's like what occlusion on dots, lines, guidance. We know all that. Okay, tell about something different. Patient is not able to sleep, so she is entered into the next zone after ODD. Then I told her that's a different ball game. We need to get trained in a different way. That is the level of discussion what she does with us. Okay, husband, he has done POS, sir.
I dropped it.
Okay.
FMR.
Husband has done FMR already from sir. From there the journey started. And she is a very, very, very sincere and dedicated clinician I have seen. And after coming here, after seeing every one of you, she felt, okay sir, let me do it. So it's a white card entry. You won't see the name there. Okay? Fine. Yeah.
First of all, I would like to thank for the opportunity and an amazing journey with Dr. Vasanth sir, Dr. Mallar ma'am, Dr. Ramesh sir, and all the support from Vijaya ma'am as usual. So, as said, it's a wild entry, and anything wrong, just please. And this is my first presentation on the stage. So, let me start with the case. The patient, he himself is an orthopedician. He came for orthopedician, yeah. He came for restoring his smile, which is lost due to fractures, decayed and missing teeth. He always used to complain of the frequently dislodged upper anterior, which was done prior. As such, there were no muscle symptoms, no pain, but he remembers having a click on the right side, which is now not there after he got his tooth extracted somewhere else, long time before. So these are his pre-op pictures. The main thing for this is I want to emphasize on the importance of the anterior coupling in this. It was a challenge for this. So COAS deprogrammer was given, phase pose was taken, and for the CR bite, the COAS deprogrammer is slightly modified to cover the the upper labial aspect, and a cone was prepared for the composite indexing. And then first point of contact was matched, and then the mounted models with phase bow and CR. So as planned, we were planning to do this as two phases. Phase 1 is for developing the anterior guidance with the planned temporaries, because that is to fix the front wheel of the auto. And then the second, and during that phase, once he gets adapted for that temporary planned temporaries, implants were placed, and they were left to integrate. And the treatment planned vertical was 0.5. Being an additive, all this anterior coupling and overjet and all were taken care in the second phase. And the joint crowns were planned for 1.4 to 1.7 and 2.3, considering to the perio and the oral hygiene part. And this is the mind mapping. This is a wax up done. That's an overjet view. And this is what I want to stress, that temporaries, the points, the dots, the lines and all been adjusted in the temporaries, and they were given until the implants were osseointegrated. These are the dots and lines before and after temporaries. And group function has to be given till the molar to achieve the non-functional disocclusion. And anterior guidance were given from the centrals and the lateral. Patient, after the 6 months, he was comfortable with and in harmony with the planned temporaries. So we thought to go ahead with the same thing. Digitally planned for the crowns, layered zirconia given, and screw retain process for the anterior implants. These were the scans. Screw retained process, and these are the final. And the OPG, and one more thing is, there was no need of root canal for any of the tooth because the prep was very minimal, and the anterior, since the anterior guidance was established, these are the final pictures. Finals with dots and lines. This is how it was transformed from that to this with the emphasis on anterior coupling. And now he's like very happy, no more dislodged bridges, crowns and all that. Thank you. I'm very grateful for this opportunity. Thank you.
Thank you. Thank you. In short time, she's just opened a very impressive case. Thank you. Thanks a lot. Thanks a lot. Lucas. No. Janos is the first.
Janos goes.
Okay. By the way, Janos Mako, everybody knows. We have been telling you Janos. So
the occlusal compass went through our head.
It went through everywhere. Okay. Fine, sir. Yeah, please.
We were supposed to start in the morning. Thanks. First and foremost, thank you so much. ODD has been an amazing journey. We had been running after occlusion, as sir rightly said, after graduation and after into private practice for a very, very long time. We always used to look for answers for questions which were not answered. We were hunting out for courses, 1 way, 2 way, 3 way. Finally, in one of the courses, we landed up meeting Dr. Ramesh, and then we were further introduced with his seeds group. That is where we knew that yes, we are now on the right track. So thank you so much. And once when he was to start with his ODD course, there were no second thoughts. Yes, we were to join it. So
you haven't left much for me. So for me, my occlusion journey started, I would say 12, 13 years back, when I would just keep nudging him that whenever we do anything, a filling or a FPD, why should the patient adjust to it? It should be comfortable for the patient. And my pestering and asking him again and again, we should do something about it. We didn't know back then, occlusion or detail about it. So one fine day he said, I have ordered something for you. I was like, okay. Then, and a big fat Dawson lands in my lap. And totally new to it, reading, starting from the first page, it's like it used to take me really long to actually finish one page also. As one of the fellow members also said, the language is such that it will take you long to interpret what exactly he wants to say. And that is when I'll just take over from the seeds group. From there, whenever Dr. Ramesh used to start his presentation, he used to thank God first. We all know that the first slide is thanking God. And the next slide is yours, Dr. Vasanth. He thanks his mentor. And I was in awe, how would Dr. Vasanth be that he is in so much of gratitude towards him. And I'm totally, we all can understand what his expression is and what you are. We need not put it into words anymore. And I don't think I can do the justice to that also. What we have received, and because everyone can show us beautiful slides, beautifully completed cases, but no one will show the drawbacks, or no one will show the actual failures behind it, or the depth of the questions, answers that I've got from you. That, sir, please tell me, is because at times there is something in theory and there is something in practical which is clashing. It was not going right for me. It was not, syncing for me. I was like, it's written, but what I achieve from doing something else is different. So please answer me. And he was like, yes, you're right. So he was generous and honest, and he had the courage to at least tell me and put up his point. Beat whatever has been written anywhere. You can just share the truth to me. And I'm totally grateful for that. Because otherwise, the conflict was always there in my mind, that it's not matching. Whatever is written and whatever I achieve when I'm doing, it's different. That clash was always there, and you gave that peace in my mind, and I'm totally grateful for it. Yes, thank you so much.
Thank you.
And you are the major medium to open these eyes towards us, because equilibration, what I studied in Dawson, was like, I went through again and again and again and again. I was like, okay, then I could make 1 or 2 pointers. But then through you, it was
There was just
beautiful.
that small paragraph in Dawson about equilibration. Okay,
It's a
yes.
small
And then
paragraph,
how do you
yeah.
do?
So thank you so much.
With this
And
note of thanks and gratitude towards everyone, so we'll be starting up with our first case. This is a case of medico. Since everyone is aware of medicos, they are like bad with when it comes to their teeth, probably because of their profession. They focus so much on caring about others. The main complaint of this particular patient, he was not happy with the way his teeth looked. That was obviously a secondary one. Primarily, he was developing spaces and there were food lodgement happening. So he got a reference from someone that why don't you go and meet Dr. Madan's. So this is where we started our first step. The steps, as very rightly mentioned in ODD, now we very, very strictly follow, although there were a few additions which were done for this. So we started with a comprehensive consult and gradually proceeded. After the consultation was done and in-depth explanation of how the particular process has to go, the patient was all in. He said, okay doc, you are fine, just go for it. And although I was planning not to mention, but he is actually one of the head of departments of very premier hospitals in Gurgaon, Medanta Hospital. And he himself, being a plastic surgeon, he said a yes was another big thing coming up, okay, we have to do a case to the next level. So we started with the self-evaluation records. More or less, there were no complaints. The muscles were very tight, but he was having no pains. TMJ was normal. Teeth were showing the signs of, I think it's not very clear. So teeth were showing the signs of occlusal instability. You name a sign, it was there. I'll just directly focus on this particular slide. You name a thing, attrition, abfraction, erosions, he had everything. But fortunately, all his teeth were fine. There was sensitivity in quite a few. So this is how we started the case. This is how his smile view was. Finally, when we came to startup, as sir also knows, we are doing all the cases now both ways. We are doing digital as well as analog way. We took impressions, intraoral scan, CR bite record was done, mounting was done on the articulator, incorporating the vertical pin reading. Finally deciding the treatment vertical, taking into consideration some DSD protocols also. The incisal edge position was conveyed to the lab along with the models and the photographs. The lower mounting done. The first point of contact on the model and the mouth. This was the, I think everyone can make out, this is the happiest moment that yes, we are right. In fact, just to add on to this, on this particular point, we used to even just to see how good our scanners, digital intraoral scanners are working. So I used to take a scan and I used to see whether that particular point is coming or not, and it was absolutely the same. So that approved, okay, fine, even the digital might be correct. So coming on to then the treatment planning with the equilibration chart sheet, mind mapping was done since all teeth were vital, but his upper anteriors, the palatal erosion had taken a toll. So we decided to go for 3 to 3 crowns and posteriors tabletops. Lowers, we planned to go for veneers. Lab instruction sheet. Lab was given instructions. They were like, sir, what are you sending? These are 3 pages. So, but still they could like, okay, fine, whatever you say, we will go ahead. Since it was more of a additive case, so we decided, and wax up was done. After the wax up was transferred in the patient's mouth, to be very frank, this part, Dr. Swati, she takes over because I don't do any of the adjustment. She is the one who's spending time. And as I was mentioning, so we just, after all the adjustments were done, we just took a intraoral scan to see whether all the things are correct or not. Coming on to provisionals in the mouth, and then very, very important, the test drive approval by the patient. He was so happy, he's told, okay, I am fine with this, you just leave me. I am okay with this also. So after this, then we started with the preps through the temps, and this is how the upper full crowns and the models were done. After the uppers were placed, so this is like everything fancy is not what we are here to discuss or to share. So when this was done, there was a spacing. There was no anterior contact. So we took a fresh cat bite, and the upper anteriors, they were sent for modification, and this is how we got the final contact in the anteriors. After the anteriors contact was established, that is when we started with the lowers. So lowers, we took a posterior prep, bite records. We took both ways. We had taken the intraoral scan also, but specific instructions were given to the lab to not to do the mounting as per the bite what is received. We send him a physical bite, and this is how the tabletops looked like. After the posteriors, they were placed in the mouth, and this is what we get in the end. This is how his smile was. These were the dynamics, what were achieved. So the upper palatal and lower lingual views to show the tabletops. The post-ops, this is how the post-ops were. Thank you so much.
So Mrs. Mehra, one of our patients, in November 2020, she lands up to us with a dental pain. So on examination, that has to be treated endodontically. She was explained about the thing. Now the thing was, when the history was shared with us, she stays in US. Whenever any dental pain was there, she had to go under extraction for every single tooth, and that too under sedation. That was the kind of dental phobia she had. So multiple molars, none of them there, only one of the tooth was there, 3-6, to which we told her and educated about how important that tooth is. It's firm, don't go ahead with the extraction. And we motivated her, consulted her on how to go ahead with, and under non-sedation, only under anesthesia, local anesthesia. Dinesh performed the endo treatment. And that was a big leap for us. And somehow maybe that was the stepping stone also for the confidence and the trust that she had, from doing one root canal to actually landing up doing a FMR case. So that was a big achievement for during that time. But the thing is, that time we had not joined ODD, and she doesn't stay here. We ended up doing, then because of COVID and her age, she didn't turn up till 23. So 2023 she came in the January. And in fact in 2020 we told her about how mutilated her bite was, how compromised her dentition was. She understood the concept, but she didn't have the courage to go ahead with any of that. But we convinced her to go ahead with at least splint, so that whatever damage is there, we can just stop there. She understood and somehow took step for that one. We gave her the splint, and in 23 she came back. Maybe because of the benefit of the splint and the comfort that she felt after that. That gave her the confidence, and she was all motivated and charged up that this time I want to do something about my teeth. So that is when in 23 we made a plan for her. Entire All the records were taken. For us, this thing, for our advantage, the TMJ was fine. The teeth were definitely compromised. We took all the records. Everything was, all the tests, we explained her, we designed the thing, and take the photograph records. All the montography was recorded. We also did the scan along with this, the uppers, the lowers. And that is when the treatment was explained. We decided to take the baby steps. Multiple implants were needed. We started with the third quadrant, where we did only single implant in the first sitting. And then after a gap of a week, we did another implant. And by the third week, she became a pro, and she said, entire right side, I'm going to do one go. We did 4 implants for her in the third sitting. Our oral surgeon does the implants, none of us do. We don't really do the implants. And then again, after a year, she came in 24. That is when the prosthetic stage started for us. We took all the records.
I would like to just add here, that was precisely the time in 24 when we were done with our second module, and then the treatment plan just changed. So everything, the focus of how the planning has to be, she'll just go ahead.
Yeah, we had, as Dr. Ramesh really said, for one of the cases, that initially the things were a little cloudy, whether we are doing it rightly. Is the CR correct? Is the planning correct? Is the execution correct? Because occlusion needs to be refined every time. So that brought a doubt in our mind, is it right? But then that is when, this is again the clarity that I got from you, sir, that occlusion takes time to settle. There is a settling phase for that also. So somewhere that all those things combined gave us the confidence and gave us a better clarity to design a case. So keeping all those things in mind, we designed, and we were more confident of delivering what we are planning also. So I'm not getting the Facebook records image of that. Yeah. So all the records were taken, the Facebook records, the CR. Okay. So the all the mounting protocols were followed, and we did all this on our own, definitely not taking any help from our assistants, right from the mixing to the mounting. Again, this was the equilibration chart sheet for us. This was the planning that we went ahead with. Since all the anterior teeth were also compromised, we decided for the cappings for the anterior teeth, upper anteriors, and venous for the lower anteriors. There were 4 teeth in the entire mouth which we decided not to touch. They were the 4-4, 4-5, 2-4, and 2-7. The anterior coupling, we only did it in the clinic on the articulators with the composites. After that was done, we also, the entire designing for the bite, for the posteriors, everything was done with us. We made the silicone putty with that, transferred in the patient's mouth, achieved the dots and the lines, then all the, in the excursives and the static movements, everything was recorded. And this is when we took the approval for the case from the patient as well. To which he agreed, and that is how we proceeded, taking the further records again. The prostheses were finalized. Again, in this case, we had a challenge. The thing was, all the abutments here were milled. And as you can see on the first quadrant and the second quadrant, the uppers mainly, the abutments were really long. So we went ahead and did the luting with the rest of the teeth, rest of the crowns and the prostheses. Only the uppers were sent again, with the bite was recorded again, and the modifications were done, necessary modifications were done, and then the prostheses were luted again. So this is what we achieve after that. Everything according to the ODD rules, and doing every step, going up to the detail of every nick and thing, whatever was taught to us. The occlusal woof for the upper, the lower, the dots and the lines, the protrusive records, and this is here. Finally achieving what we dreamt of, what we thought of. Yeah. Thank you. Yes, this is the main slide.
she was so happy after the process. Everything was done. Like even at the time when we used to take a test drive and we used to take photographs, she was so high on energy. Just by looking at her, you could never make out that she's 80 plus. She used to go for walks and she used to go for gyms without fail. And when it came that, okay, yes, we have to give her a session, she asked, okay, how long? And since when we work, we start up early, we said, you give us just one day, we'll just go ahead and finish the whole thing in 6 hours. She kept on asking, you'll take photographs now, irrespective of whether it is intraoral or extraoral. But she was like so happy when the process was done. So overall, like she was
I've
very,
never
very
seen anyone so excited about the photographs. Aaj photographs hoga kya? Aaj photographs hoga kya? And finally she was super excited to get the photographs done. Yeah.
Thank you so much.
Thank you so much.
Thank you for this wonderful presentation. So we are so happy. The level of documentation you can see, no? So I just wanted you people, when you wanted to follow something about documentation, I just strongly suggest you to follow them, and they have been phenomenal. They were into completely digital. We dragged them entirely into analog, which is a huge change in the thought process. Okay. So since the presentations has become more, I'm just going to conclude in another 10 minutes. Okay. So everybody is happy? Happy? Everybody feels proud. How many of you feel proud here? Huh? He is raising both his hands. I am proud. So it's not a easy journey, right? You can see the struggles. Can you see the pains behind everyone's story? Yeah, please.
School days and college days, we were always hesitant of asking. You know, the teachers, somehow I felt that they expect us to just know. You know, asking was never appreciated and never very, I was not very comfortable asking. But when I joined the course, I was like, abhi nahi to kab. I was like, I have to ask, I have to get answers for everything that I have a doubt for.
Did you get it?
Yes, absolutely.
So now we are just sharing two more cases rather. I hope it is not boring. So one of the cases that patient was also referred to us. This is with a disc displacement with reduction, and he had a major click. So let me just directly start from here.
Referred to us by one of the dentists.
Start again. Let's see. Check one.
Yes. This is on normal. Okay. I hope everyone can hear it.
This is the extent of click he had.
That is why we wanted the audio. So as per the date, this patient reported to us on 16th October 23. And then after that, now since we were aware of, we took CBCT, scans, MRI, there were changes in the disc. His disc had actually perforations also. And then we started, one second. This was after we gave him a deprogrammer. His jaw was not getting space, so we we gave a Cois type, something like a modified DASA, not a full coverage, and then we could manage to take his CR bite. By this time, he felt a lot of relief in the tension what he was getting in his muscles. Proceeded with the protocols, and finally we gave him a full coverage splint, which is being shown here with all the guidances and the static stops. This is how it looked. His one second. I hope everyone can appreciate the click had almost reduced, but yes, the deviation was still there. 15 days. 15 days. 15 days of the splint.
But the treatment is still going on because there are so many changes that are still happening. The kind of
Initially, we gave the deprogrammer, then we made the full coverage splint. I think it was for probably 2-3 days.
yes, not more than that.
Because when the disc is involved, although his load test was negative, but still we didn't want to take any chance. So wherever we were getting the CR, and then when it was a definitive thing, we proceeded.
So what we recorded was a CR for of the day. Yeah, bite of the day. So we started from there.
Is it digitally printed or that's plain?
No.
No.
This was done with the self-cure.
Yeah. You straight.
So this, he's been very, very regular, and he used to come for recall. Then he was missing somewhere in between for like when everything was stable. He used to come for recall after a gap of like 3 months. But every time he used to come, he used to say that yes, now he's feeling better. And he was actually inclined towards that, when are you going to start with my rehab? Even last week also when he came, his question was, now everything is fine, now what all you want? Now proceed for the final rehab process. So then this is how it was after a year. The same stops. Every time Swati, whenever this patient used to come, Swati used to spend around good 1.5 hours. He used to come every Saturday. I used to ask, everything is fine, now what are you doing? Okay. So, but no questions further. Then when the results came, it is like, this was in November last year. He could feel that there is some change. Now, when Swati saw that, okay, see, now this is a change, what is happening? Now she'll proceed further.
He could actually feel that the jaw has gone back. So in the top picture, we can see this is where that splint was fabricated when in the last visit. And that by the next time, he felt that his jaw has gone back. And I actually made Dinesh click a picture for me that actually the position has changed. We again modified the splint, redid the things. This is where we've already done so many modifications in the splint for him, because every time changes are happening.
This was the intraoral photograph. Without the splint, he could feel that this is where his teeth were touching, but he can make out that yes, now it is in the lower one. So after some further modifications, then he was still feeling all the more change. And that is when in this year, in January, we again made a fresh splint, because all his posteriors were out of bite. He was getting only contacts in the front. Although there was no discomfort, nothing, but then we thought probably now it has gone beyond a limit, so let us just do a change. So this is where we...
Because the position where this actually the CR was coming that time, there was a lot of discrepancy between that position of the CR of that day and what the splint was done earlier, because the changes had happened. So many changes had happened at the joint level.
Actually, it was too much of a work to cut off, remove all the acrylic and then fabricate. So it was better to do it fresh altogether.
The situation was only anteriors were touching and the posteriors there was no contact.
Then in April this year, we thought, how about to just get a check and get his MRI repeated. I think perforations were no longer there in the disc. But when I had a word with the radiologist, they could not understand when we asked them about how is the position of the lateral collateral ligament and how are the muscles. Can you give some details of those?
At least the position of the splint, since the click is gone, there's so many changes happening. There was deflection, complete deflection. And in the patient words, the thing was like, my left jaw was stuck. कि जाम था. There was no movement there. An entire movement jaw was opening. Now I can feel the things happening. Then there was a moment when the click started happening on the left as well, because again it was modifying. Now the situation is the click is, none of the joint has a click. There's a very smooth opening of the joint. If we have the latest video, we can just straight away show. Okay.
So this is the last change which has happened now in May, 14th of May, that even after the new splint, his jaw is now relaxing further. This was a time when he wore the splint. His words were that he was very much into meditation and all those things. He said, the moment I wear the splint, within just 20 seconds, I feel as if my body does not exist. I am floating.
I'm floating.
Because
I was like, this happens in meditation. This is the ultimate aim of meditation, what you're saying.
Because
I can sleep. Earlier he had disturbed sleep also. He could not sleep.
Because whenever we are doing, whenever any splint recalls, anything has to be done. So we have actually made our clinic, we just shut off all the lights and there is a soothing meditation music which is going in the background, and patient just lies down. We never do any, she never does any splint checkups or anything in the sitting position. Patient just lies down, and these were his words. He said that within the moment I wear and I lie down, within 20 seconds, I feel the chair is not there and I am actually floating.
He was on the chair and suddenly he did this. I said, what happened? The same thing happened again. That I'm just coming back to the conscious part from the meditation. There's one more case that we'll share.
Actually, these are a bit different ones since they are not FMR cases. So, just to give a background of this particular case, this patient, she had had TMJ issues for more than 15 years. She had some fractures, some IMF done way back, some 12, 14 years back, and not comfortable with the bite. Some things just keep on going on. So, in the case which I shared with you, so that doctor, he sent me these photographs. He said, do you think that we can work or do anything for a case like this? I said, like, okay, what the case is, just give me some brief history. So this is how it was. This was a case of orofacial dystonia. She had tremors.
Uncontrolled
Uncontrolled.
tremors, which could long up to few hours, 2 to 3 hours to 2 to 3 days as well. And whenever these used to happen, she used to be admitted to the hospital in the ICU, given multiple drips and everything, but not under control. And she was even diagnosed as facial palsy patient, given all the neuromedicines, but nothing was helping her.
So her all MRI, everything was done. Then finally, she was referred to India for further treatment. She had actually taken an appointment that, okay, it is not getting cured. I will get some Botox done or whatever has to be done. I will get my jaw replaced. She had actually come to India for replacement of her TMJ. That is when the patient was referred to us. This is last year. This is how the situation was when she came to us on 26th. This is what happened. The moment I did a checkup for her, and it just started. And this is after just 20 seconds after Swati did a checkup for her. We just told her to just relax. The moment the muscle releases were done, and she was off the tremors.
Open the maximum you can.
She was very scared to open because any movements she was
There was a fear of triggering of these tremors again.
She was on baby food for a long time, maybe 8 to 9 months. When she came to India, she had a bag which was full of baby food, Cerelac or baby biscuits, because she could not even think of eating anything more than that. There are muscle releases what she did. This is how it was. In fact, everyone was like, we ourselves were like so much zapped on what has happened.
Close. Open the maximum that you can.
And when this was being done, same way as I mentioned, the lights were off and Swati just did a palpation or relaxation for her. With eyes closed, we just became a media to just cure her. There is some superpower which was working. So this is how her intraoral situation was. And we took all the photographs, everything, but crux of the presentation is that touchwood, she has not reported with the tremors after that. That was the last.
That was the last.
And they are here again in India. They just reached last night. So they were waiting. They are now waiting for us. For the next week, they have a full follow-up again. So that's it. So we just wanted to share.
Sharing our splint journey with you all.
This is how your, that's I'm concluding here. After this ODD journey, once you start doing all this, you will come up with some challenges. These are all challenging cases. They are into the next zone of getting into all the complicated cases which has to be handled. Believe me, over a period of time, within a year or 6 months, people will start inquiring about you and they will reach out for you for all these problems. Do you understand? So this is something like ODD challenges. Okay, there are something called ODD challenges. What do you mean by ODD challenges? You have a philosophy now. You have a protocol, what you are following. Nothing is going to change in that. Okay, but end of the day, you will face some challenges after this. Okay, there is no presentation, nothing. We don't have time for all that. Right? I'll just put the challenges. Yes, sir.
Particular patient, I just forgot to mention, we gave a full coverage occlusal splint for her. And then she is now very, very regular wearing it. And all the exercises, everything was given, was told to her because she does not stay here. And after like 3 months, we did a video call on how the things were. And her husband now, he made videos of how the muscle releases have to be done. Okay, if it happens again, then what is he supposed to do? I said, like, we don't know. So, but fortunately, the thing is not recurred. Just wanted to add because all this was possible just with the split.
Okay, fine. So we are going to conclude the symposium by just saying thank you to everyone, of course. So believe me, you have started an incredible journey in your life and you are going to thank everyone here. Especially you will thank us for life, believe me. Because this is a very, very emotional moment for us. To be frank with you, of course, I start my slides with thanking God for everything and the academy. What do you mean by challenges in ODD? End of the day, once you are into this philosophy, you are going to go back thinking you know everything. But believe me, there are a lot to learn. Okay, I have been into all this. Don't think this only ODD is going to solve all your patients' problem. See, somebody coming like this with a tremor and dystonia, what are you going to do? So this will make you run on your toes, go and find answers, or refer to a right place where they do the job. Only 2 options are available. Don't try to. So the challenges here is don't try to be or don't get tempted to touch all the case. That's my first warning to you. Okay? Be aware of what you are doing. Be within your limitations. Know your knowledge level. Only touch what you can do, what you can legally practice in India. Because there are a lot of courses that is going to go there and where people will come. So what do you mean by challenges? Of course, I need to thank. I have to thank all these 3 people. I don't have to repeat all this. Okay, these are the 5 things I feel will be your challenge when you go back after graduation. Only 5 things. First thing is, you are learning something. There will be a situation where you need to unlearn something. You need to relearn again. Maybe what we are teaching today, we may contradict next year. Okay, maybe the next course we may contradict. Do you understand what I'm trying to say? Learning, these 3 steps are very, very important. Don't click to one concept and be there. Go everywhere, learn everything, question everything and apply what is applicable for your practice. Job done. Next challenge will be, biggest challenge will be your consultation with the patient. End of the day, you have knowledge. If you don't have the patient on the chair, what are you going to deliver? So that you have to master. If you are not, the first challenge is learning, relearning, unlearning. The next challenge is your consultation has to improve. If you are not good at communication skill, accept it. If you are not good at talking with patient, accept it. If you are not good at practice management, accept it. Find a right mentor. Find the right place. Go to them. Learn. Expert. Because end of the day, that is important. How you make the patient feel is more than important than your ODD philosophy itself. Do you understand? You may be the phenomenal clinician. If the patient is not sitting on your chair, what will be there? Believe me, if you are not going to follow the second challenge, you are going to fail in this ODD practice. Be aware of that. The third will be, there will be critical challenges in ODD FMR, right? The steps. Some steps are really critical. Your mounting is critical. Okay, your planning on the articulator is very, very critical. Execution in a systematic step. But I feel this third step, everybody will be phenomenal. Believe me, you just start doing cases. Thus, that challenge can be handled if you are attaching with us for life. For example, after graduation, every alumni webinar, be there. Show up. Show up. Be in the curriculum. Always be there. We will be adding, we will be changing. Whatever we said in the 2024 will change in 2025, 2026. We don't know whether we'll be teaching CR. I'm just kidding, right? Possible, right? Be in the journey. That will be the third challenge. Fourth one is the biggest challenge you will be tempted to do canine rise on every case. Please. Interceptive protocols has to be reserved for, because what will happen is you are planning something around a simple an FMR. If you have convinced, if you have educated them, they'll take up. So why do you want to put interceptive protocols for every case? Don't get tempted to do all the adjustments in MIP dentistry. MIP, stick to what the patient walks in. Try to give best possible solution. You may not give the same occlusion at all. Okay, canine rise is just an example, because what I have seen people doing it left and right, you can do it. But canine rise also needs a lot of respect. I articulate, I see in the model, Rupa is here, you ask her. That's like that I don't do. I plan a lot, but clinical execution will be very small, but planning should be there. So MIP dentistry, it is challenging. For me, FMR is not challenging. MIP is challenging, because I should not screw the bite, right? Then build your ODD practice. You have to aim at it. Your ODD practice, you have to build a team. You have to build a lab. Okay, I'm not saying in the sense building a lab, building the right team around you. For example, if a case comes like this, if it is beyond your limit, don't ever think about referring. Create a team of people, right? So, for example, you are asking about muscle relaxing exercise. No, I have been following these people. Name this word, okay? It's called neurokinetic therapy. Okay, in Delhi, people are conducting courses. No, it's a very, very nice course for muscle. It's for physiotherapists. But I am planning to attend. The biggest problem there is, at the 4th level, they are teaching how to release lateral pterygoid. Do you understand? At the 4th level. By that time, I should spend a lot of money and time to reach that level. But that is this there in my wish list. If at all I do, naturally, it is going to flow in the ODD, right? The best parts will always come in ODD. So build your ODD clinical practice. You have to build. You will enjoy this journey. You will love it. Your number of patients may not be great, but that few patients will give you a lot of satisfaction. What more do we want? He's floating in the chair here with a splint therapy. What more can you give? What is the best solution about this we can give to a patient? I'm able to sleep in 20 seconds. Think about that, right? So always remember, this symposium is concluding now by saying you are going to face challenges. Challenges will be there. Don't be afraid. Jump into it. Reach out to us. People who ask for help will thrive. If you are not going to ask for help, you are going to fail. Do you understand? You cannot have solution for everything, right? Okay? Ask for help. Be in the race. Be in the race. Show up on all the alumni webinars. That is what is this entire presentation is about. I'm not going to go into, we don't have time for all that. Sorry, Muller. Okay, so what I'm trying to show here is, see here, building your ODD clinical practice is nothing but building lives. We are building lives, right? See, all these are like phenomenal cases where I always say about this woman, she doesn't want to take the file out of my clinic. She doesn't want to receive the file. She's saying our bond is broken, sir, if you receive the file. She doesn't want to get the file back. All these are like, it's not an easy case. She travels all the way from US, stays here. Okay, this is called building the practice. You know, everybody knows the name. Okay, even if I forget, you will never forget. The beauty here is, why I am saying this as a challenge is, she loves this smile, it seems. She doesn't like that. Think about my situation after 8 months or 1 year of hard work, a patient giving a statement. This was not proclaimed, that was proclaimed. Okay, you will land up with such people. Don't worry about it. Just be in the journey. See, these are all changes. For your orthodontic work, and recently I finished with equilibration. Just to make you understand, this is what is going to make you run is this gratitude-filled patients. Look upon them. Build your journey on that. Okay, this ODD symposium has been phenomenal. Frankly speaking, we finished on time. We wanted to give extra time for people here, and very, very happy about it. And I want to conclude by saying, of course, whatever may be the challenge, one word, what sir said, it was rightly 2.5 years back we started this journey. ODD Academy was dedicated, and this is the day, this was the dream, this was the goal. Definitely sir will accept that. This was the goal, right? Dedication anybody can do. But achieving something and proving that your dedication in your start of the process, your curriculum is correct. This is this banner we printed midnight 2 o'clock from Guduanjeri. It was a far place. We printed it and we made it a point you bring it, because I know you people will like it. Morning I saw everybody showing here and taking photographs. At the end of the day, it's an achievement. Radheshyam sir was jumping to that height of this banner. He was so happy to see. Seriously, we want to put all the pictures. Sam wanted to do everything. We didn't have time. Why did we do it? This is proof for our dedication and whatever we have delivered. Always remember this, okay? Whatever may be the challenge, we the mentors of VASANTH Dental Academy, we will be always there for you, and of course with the great coordination of Vijaya ma'am. Okay, other parts, they are there. Content wise, we are there. So we are there. Can I repeat again? We are there. The graduation may be over, everything was over, but be with us, make us feel proud. Every day when you walk into the clinic, make us feel proud. Remember us for a second, then you will understand the amount of hard work we have put. Every hands-on, every lecture, every online lecture, every video lecture. Don't ever think like we always create everything with the same passion, same dedication, same energy, same love. There is not even a drop you can see in our entire presentations. Even if it is offline or online, whatever it is, we have given whatever that is possible that God has given, we have put our 200% into it. But we wanted you to achieve like this. Dream big, get into the world, create more ODD dentists. Okay, so I don't have to tell you that you need to recommend a ODD course video. You all will do it. We don't even believe. Have you seen any marketing post from our side? We don't even have time to do it. Ma'am always asks, we should put Ramesh. Why you are going here and there? Why are you not? Seriously speaking, the only place I'll remember is waiting time in the airport. No, there I'll put, I'm going here. That's all. Okay, so we don't need marketing. If you are too good at something and if your intentions are pure at what you are doing, we don't have to do marketing. It will happen by itself. God will bless you there. Okay, so we are there. That's the final statement I'm giving. We are there for you, whatever may be the situation. Huh? Shall I start, Sam? Sam here? Sam is here? Huh? Okay. So, this may not be very, very an academic one. But I need to conclude with everybody has their own style to conclude, right? Fine. So always remember, people in Tamil Nadu will know this, right? So, when you go back to the world with all this graduation certificate, you go there, okay? So this is what you will face, but we wanted you to come out like this, okay? This is just for, maybe just for fun or whatever it is. This is the reality. You should walk like a lion. Okay, walk like a lion. Let's see what are, I gave the dream, what they have created. People can relate this, right? Hero!
ఎవడు మాట.
Enough? Ma'am and we are big fan of Rajnikant, so she will love it. The point here is, this is how you will become. People always ask me, sir, how are you so confident when you want to talk with the patient? Simple, I know occlusion. Nothing else. If you know that, any part of dentistry, you will become Rajnikant of dentistry. Believe me, okay? So I conclude that I want sir to conclude and finish this symposium. You loved this video? Yeah. Okay. Thank you, Blessy, my son Jeevan, and who all did Malar. Everybody who has done this. I'll put it. Only thing is, you shouldn't forward this to the director and the producer. We'll land up in some other problem. Okay. So, okay. Whenever I feel about this scene, no, exactly the same scene, one day, I will walk into my practice like this. All these crowns, all these veneers, cast partial, everything should put down and I should walk like a lion. Seriously, occlusion will make you do that. Sir, please, sir. Sir,
my eyes went moist. I'm never an emotional person. I thought so at least. But you guys made it to me. Power of ODD, sir. The name is odd. No?
Odd. Odd man out. So, I always used to wonder, why is always into, I used to think, I used to feel very bad. Why is always after course, this and that. I hope he stops teaching kind of.
Now she won't say that. No, she won't say it like that.
Like that, no? Because always like WhatsApp, group message, answering this, answering that, even wherever we are, I was thinking, I don't know when he's going to stop teaching.
Answer, right?
Not now, it's been 25 years. And I'm so happy whenever Ramesh accompanies him, something's relieved from him. There is somebody to take care of him, kind of. Even when they go to Vishnu Dental College, I was not accompanying him. I said, Mallar, I'm not coming. You are going to take care of it. So I'm so happy that you are there for him. No, like that, he's always there and he will be there. No, he's becoming, his dreams are coming through him now. I mean, now I feel very bad. I shouldn't have even thought about, why is he doing his courses? Like, I shouldn't have thought about it. Anyway, I'm so happy. But for Ramesh and Mallar, he couldn't have achieved this. Yes, absolutely. Absolutely. This is my bottom of my heart. Even right from everything, even arranging this, we have no clue what they're going to do. He said, sir, you CPD, he was with CPD for the past 1 week. Like, didn't even come out of the room. My sister-in-law had come, his older sister. I told him, see, they are there, not even coming out of the room. I mean, they understand him very well, but still, he was with CPD course.
This is the book, okay. There's one participant in the final day, he just came here, sir. I cannot reveal the name. Okay, just he came to me, sir, what do you know what I thought? When the cast partial was announced, then they said around 50,000 I'm going to spend. What are they going to teach? 50,000 is the thought process, sir, frankly speaking. I came inside, I just sat, I took the book, the exact words, ma'am. I took the book, I saw the contents, I saw the papers, I saw the quality of printing, the quality of work, what you have done, sir. I thought like it's worth. Forget it. Whatever I'm going to do,
I know.
but it's okay.
No, he's been at it right from when we came back only on June 12th. Like, he's been started about a month back, and then all of a sudden, last week he wanted to change some structure in that, which is that exercises, quizzes and answers, no? That's it. If he thinks something, he has to do it. So it was on and on. It never ended. Even then, I found a mistake yesterday. No, you should have given out the answers. Because they were all so cloudy when you said the rest here, the eye bar here, this and that. They cannot visualize it. And then I told him like,
I
said, see, I am the person talking like asking to go give out the answers because, you know, I was a person, oh, no, enough kind of a person, right? Then I said, no, I think you should give out, at least have one webinar for them. Give out the answers for them because they are so cloudy now. With this, because new concept for them. Now I feel, you know, I'm so satisfied, I'm happy. I think he will appreciate.
Certificate of appreciation for everybody who has attended the ODC. I'll just announce the name. Please come and get it, right? Okay, Dr.Swati Madan. Dr. Jyoti. You all know I'm going to call names, no? Dr. Ronak. Just be in the same order, no?